Episode 40, a football player collapses after sprints. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and answer some practice questions. The case today is a 19-year-old African-American football player in Texas. He had a past medical history of seasonal allergies around age 13 with some fatigue and shortness of breath with exercise when he started playing basketball, which the thinking was may have been exercise-induced asthma. Socially, he denied tobacco, drug, or alcohol use. Past family history was notable for an aunt with sickle cell trait, but no confirmed knowledge of individual sickle cell trait. He was training in late September during a conditioning workout. The session started at 4 o'clock in the afternoon with indoor weightlifting. At 4:30, the team went outside for a sprint workout. The weather was described as mild. The turf temperature was 76 degrees Fahrenheit with a light wind. The drill was 16 sprints of 100 yards each, and the rest breaks were 1 minute between each of the first 4 sprints, 2 minutes between each of the next 4 sprints, and then back down to 1 minute between each of the final 8 sprints. According to media reports, the player may have started to struggle and lag behind his teammates during the final sprints. But around 4:55 p.m., roughly 25 minutes after starting the sprint workout, he finished the drill and immediately complained of shortness of breath and lower extremity discomfort. He was initially alert, but over the next 10 minutes, he became progressively lethargic. His legs became weak enough that he could not support his own weight. He was loaded onto a cart and driven to the training room. In the training room, his legs were elevated and he was given supplemental oxygen and ventilated with a bag valve mask. So the University Emergency Medical Service arrived at 5:12 p.m. and started IV fluids, and subsequently the community EMS arrived at 5:28 p.m. By that point, he was unconscious, unresponsive to pain, with sluggish pupils, shallow respirations, and a Glasgow coma score of 3. His oxygen saturation on room air was 62%. His initial EKG showed sinus tachycardia with peak T waves in leads V2 through V3. He arrived at the emergency department at 5:52 p.m. This represented less than an hour after his sprint workout. His temperature on evaluation in the emergency department was 97 degrees Fahrenheit, and the physical exam was otherwise unchanged from that described previously. Okay, my differential diagnosis, certainly cardiac abnormalities, including hypertrophic cardiomyopathy, metabolic conditions, including diabetes or kidney disease, vascular abnormalities, including potential sickle cell disease. I'd like to recognize the authors. This article was published in Medicine and Science and Sports and Exercise by Dr. Ann Zalone and colleagues, including the late Dr. Eichner, one of the authorities on the subject. I am Scott Hall, a primary care sports medicine physician, and I am studying for my certification exam in 2026, and I hope you will join me on the journey. This podcast is for educational purposes only. In the emergency department, an arterial blood gas was obtained, and it showed a pH of 7.05 with a lactic acid of 33. Serum myoglobin testing was over 7,400, with normal being under 72. CPK started at 536, but by later that evening at 10:27, the level had reached 941,000. Serum potassium was measured at 5.2 on arrival and climbed relentlessly and reached 7.1 by 8:27 p.m. and 9.0 2 hours after that. Based on these laboratory values, he was diagnosed with acute renal failure and disseminated intravascular coagulation with a prothrombin time of 23 seconds and a PTT of 84, fibrinogen of 87, and fibrin split products over 920. Throughout the night, he bled copiously from his nose and venipuncture sites. His lower extremities were described as rigid, stiff, and unable to bend. He received 20 units of fresh frozen plasma, 10 units of packed red blood cells, 4 units of platelets. He was started on dialysis, but his hyperkalemia seemed to be refractory from treatment. Unfortunately, he died approximately 15 hours after admission. The terminal rhythm was pulsus electrical activity, almost certainly from hyperkalemic cardiac arrhythmia. The forensic autopsy confirmed what the clinical picture had suggested. The cause of death was acute exertional rhabdomyolysis associated with sickle cell trait. The pathologist found the spleen was enlarged at 250 grams and showed focal packing of sickled red blood cells. The liver was congested with developing central lobar necrosis and many sickled red cells. The kidneys showed patchy coagulative necrosis and sickled cells, and the skeletal muscles showed the hallmarks of acute rhabdomyolysis. Importantly, the heart was examined by an expert in cardiopathology and was judged to be normal. There was no autopsy evidence of hypertrophic cardiomyopathy. His brain on microscopic examination showed focal ischemic neuronal changes and rare perivascular pigmented macrophages with calcification. These findings suggested possible prior sickling episodes. This young man may have had subclinical sickling events before, but no one was aware of that. Hemoglobin electrophoresis confirmed sickle cell trait. His hemoglobin demonstrated a percentage of 55% of hemoglobin A, 41% of hemoglobin S, and 3% of hemoglobin A2. His newborn screening record, which had been on file since birth, showed sickle cell trait, but that information never made it to the university medical staff. So, key takeaways. There is a distinction between sickle cell trait and sickle cell disease. Sickle cell trait is incredibly common. About 1 in 12 African Americans carry it, and that's more than 3 million people in the United States. The vast majority of these individuals live completely normal and healthy lives. Most don't even think about it. But there is a small subset of carriers under very specific conditions in which sickle cell trait can trigger a catastrophic cascade. At the time of this paper publication, at least 15 college football players with sickle cell trait had already died from complications of exertional sickling. Not sickle cell disease, but sickle cell trait. And that number does not include high school players, basketball players, military recruits, or other athletes. The pathophysiology of sickle cell trait includes several key things. During intense, sustained exercises, 4 forces converge that can trigger sickling in someone with sickle cell trait. First is severe hypoxemia. The working muscles are consuming oxygen faster than it can be delivered. Second, metabolic acidosis. Lactic acid builds up rapidly during maximal sprinting or maximal effort. Third, hyperthermia in working muscles, even when the ambient temperature is mild. And fourth, red cell dehydration. As the red cells pass through the hyperosmotic environment of working muscle, they tend to lose water, which increases the intracellular concentration of hemoglobin S. When these 4 forces act together, hemoglobin S can polymerize. The red cells can then sickle as they become rigid and more sticky. They obstruct the microvasculature, and blood flow to the downstream muscles is compromised. The muscles literally become ischemic, and then the muscle cells will die. And that's what develops the rhabdomyolysis. Once fulminant rhabdomyolysis sets in, the contents of those dying muscle cells, including myoglobin, potassium, phosphorus, and uric acid, flood into the bloodstream. The myoglobin clogs the renal tubules, causing acute kidney injury. The potassium rises to lethal levels. DIC can develop, and if hyperkalemia isn't controlled, the heart develops a fatal arrhythmia. The authors of this paper make a compelling argument that many cases previously attributed to exertional heat illness were actually exertional sickling with only the expected physiologic hypothermia of strenuous exercise. This case is not an isolated event. It fits a very specific pattern that has been described repeatedly in the literature. The victim is typically young and an athlete, typically between 12 and 22 years old, overwhelmingly male, who collapses during or immediately after intense conditioning drills involving repeated maximum sprints. Many collapse on the first day of summer practice or early in the training season when they may be deconditioned. This presentation is distinct from sudden cardiac death. In sudden cardiac death from an arrhythmia, the athlete typically has a sudden syncopal event. In contrast, exertional sickling causes a gradual deterioration. The athlete initially starts to struggle, having reduced exercise capacity, and then they complain of muscle pain, weakness in the legs, and shortness of breath. Over the subsequent minutes, they become lethargic and then ultimately unresponsive. The authors share some important points about prevention. Screening and simple precautions can prevent deaths from sickle cell trait. Since 2010, the NCAA has mandated sickle cell trait screening for all Division I student athletes, with Divisions 2 and 3 following in 2013. All newborns in the United States have been tested since 1987. In this case, the newborn screening record existed, but the university was never provided with the information. The American Heart Association and the American College of Cardiology issued a joint scientific statement making clear that sickle cell trait alone is not grounds for disqualification from competitive sports. Athletes with sickle cell trait can and should participate, but they need specific precautions. Athletes with sickle cell trait should build up slowly in training. The tempo of drills should be moderated, and longer rest periods should be given. They should not run timed serial sprints or miles, and they should avoid any all-out sustained exertion beyond 2 to 3 minutes without a rest break. Work-rest cycles should be adjusted for heat and altitude. Hydration should be maintained, and any coexisting asthma should be addressed. Perhaps most importantly, if any athlete with sickle cell trait begins to struggle during a drill, the drill must be stopped and the athlete should lie down and receive an assessment including vital signs and potentially supplemental oxygen. If there is no immediate improvement, emergency medical services should be activated along with additional precautions including securing an AED, administering IV saline, and transportation to the nearest hospital. When the medical team is addressing coaches, the information should be simple. If athletes with sickle cell trait can set their own pace, they tend to do just fine. The danger comes when they're pushed through maximal sustained efforts, especially with serial sprinting without adequate rest. In closing, this young man was 19 years old and was apparently healthy. He initiated his conditioning workout at what should have been a fairly routine situation. The weather was fine, the drill was standard, but no one knew he actually suffered from sickle cell trait. And I'm going to quote the authors of the paper. Screening and simple precautions can prevent this unique syndrome and enable sickle cell trait athletes to thrive in their sports. That's the end of the quote. I'm going to move on to some practice questions. A team physician is evaluating a 20-year-old collegiate football player with known sickle cell trait who has collapsed during preseason conditioning drills. The athlete initially complained of leg weakness, shortness of breath, and then became progressively lethargic over several minutes. His rectal temperature was measured at 100.2 degrees Fahrenheit. His legs were described as stiff. Which of the following clinical features most reliably distinguishes exertional collapse associated with sickle cell trait from sudden cardiac death due to aventricular arrhythmia? A, the presence of peak T waves on electrocardiogram. B, gradual deterioration over several minutes with muscle pain and weakness rather than instantaneous collapse. C, a core body temperature greater than 104 degrees Fahrenheit. D, the absence of a palpable pulse at the time of collapse. And E, collapse during competition rather than during conditioning drills. The answer is B, a distinctive clinical presentation of exertional collapse associated with sickle cell trait has been described involving gradual deterioration over several minutes with coincidental symptoms including cramping, dyspnea, severe muscle pain, and weakness. This is in contrast to collapse caused by ventricular arrhythmia, which is typically instantaneous. Exertional collapse associated with sickle cell trait is also frequently misdiagnosed as exertional heat stroke, but core temperatures are typically only mildly elevated. The gradual nature of the deterioration represents a critical window during which intervention can be life-saving. Question 2. A pre-participation physical exam reveals that a 17-year-old high school football player has sickle cell trait. This is confirmed by hemoglobin electrophoresis. He is asymptomatic and has no history of exertional complications. His parents ask whether he should be disqualified from playing football. According to the AHA-ACC scientific statement on eligibility and disqualification recommendations for competitive athletes, which of the following is the most appropriate recommendation? A, the athlete should be permanently disqualified from all contact sports. B, the athlete may participate in non-contact sports only. C, recognition of sickle cell trait status is not itself a justification for disqualification from competitive sports, but specific preventative strategies should be implemented. D, the athlete should be disqualified from sports participation at any altitude above sea level. E, the athlete may participate only if hemoglobin S constitutes less than 30% of total hemoglobin. The correct answer is C. The AHA-ACC scientific statement explicitly states that the recognition of sickle cell trait is not itself a justification for disqualification for competitive sports. However, recommended preventative strategies, including adequate rest and hydration, gradual conditioning, modified pace, and emergency preparedness, should be implemented. Okay, next question. A 16-year-old high school basketball player with known sickle cell trait collapses during a conditioning drill involving repeated court sprints. He is conscious but rapidly deteriorating with severe leg pain, weakness, and tachypnea. His oxygen saturation is 68% on room air. The athletic trainer suspects exertional collapse associated with sickle cell trait. Which of the following is the most critical initial sequence of emergency interventions? A. Obtain a rectal temperature, initiate cold water immersion, and observe for 30 minutes before calling emergency medical services. B. Have the athlete walk to the training room, apply ice packs to the groin and axilla, and administer oral fluids. C. Administer an AED shock immediately, begin CPR, and defer supplemental oxygen until hospital evaluation. D. Lay the athlete down, administer high-flow supplemental oxygen, initiate intravenous normal saline, and arrange for rapid transportation to the hospital. E. Elevate the legs, administer oral rehydration solution, and monitor for spontaneous improvement over 1 hour. The correct answer is D. Collapse of an athlete with sickle cell trait is a medical emergency. The recommended initial management includes lying the athlete down, checking for vital signs, administering high-flow supplemental oxygen by face mask, initiating intravenous normal saline, cooling if necessary, and activating emergency medical services to arrange for rapid transportation to a local hospital. The emergency department should be alerted to expect for fulminant rhabdomyolysis with metabolic complications, including hyperkalemia, lactic acidosis, DIC, and acute renal failure.